You are standing right there at the bedside. You have your stethoscope around your neck, and your charting is finally caught up.
A rare moment.
Right, a very rare moment. But then suddenly, the cardiac monitor above the bed just starts blaring. You know, that high-pitched, terrifying alarm.
Oh, yeah, the one that just makes your stomach drop instantly.
Exactly. So you look up, and a bunch of chaotic, squiggly lines are just dancing across the screen, and your mind goes totally blank.
It's the worst feeling.
It really is. You're just staring at this glowing box thinking, what even is that rhythm? And way more importantly, like, what do I actually do with my hands right now?
Yeah, I mean, it is the classic paralysis of transitioning from reading a textbook in the library to standing in front of a living, breathing patient.
Totally.
The theoretical stuff suddenly becomes very, very real.
Which is exactly why we are here. So welcome to an episode of the Super Nurse Podcast, which was created by Brooke Wallace.
And for those who don't know, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
Right. Now, we should be incredibly clear right off the bat. We are not Brooke Wallace.
No, far from it.
Yeah.
But we actually have her clinical notes.
Yes.
We are using her bedside knowledge, her frameworks, and, her signature teaching style to help decode those terrifying squiggly lines.
Yeah. Our mission today is to help you, the nursing student or the brand new nurse, look at the monitor and actually understand the physics of what is happening inside your patient's chest.
We are taking on the top 5 life-threatening cardiac dysrhythmias today.
And before we start unpacking, the progressive collapse of the heart's electrical grid, we want to invite you to subscribe and watch the video version of this on YouTube.
Yeah.
The link is in the description. Just head over to our channel called Super Nurse AI.
Okay, so let's build this from the ground up, because to understand the chaos, you have to understand the baseline.
Right.
Clinical experience tells us that a normal, healthy heart is driven by the SA node. You can basically think of the SA node as the main power plant of the heart, sitting right at the very top.
Okay, the power plant.
Yeah, and it generates an electrical spark. It usually fires off at a nice, steady rate of 60 to 100 beats per minute.
And when that power plant fires, the electricity travels down the normal anatomical highways, causing the top of the heart to squeeze and then the bottom of the heart to squeeze.
Exactly.
And that creates those clean, recognizable blips on the monitor. But what happens when that main power plant just starts slowing down?
Well, when it drops below 60 beats per minute, we hit our first major topic, which is sinus bradycardia.
Right, sinus bradycardia. It's kind of like a car engine idling so low that it's about to stall out.
That's a great way to put it. It's this silent, slow threat. But the number on the screen can actually be incredibly deceiving.
Okay, this is where I want to push back on the textbook definition a little bit. If I walk into a patient's room and the monitor is flashing red because the heart rate is, say, 38, my instinct is just to panic. But does a rate of 38 mean I immediately start sprinting down the hallway to grab the crash cart?
The short answer is no. And the long answer is the absolute most important rule of bedside nursing, which is treat the patient, not the monitor.
Treat the patient, not the monitor. I love that.
You have to look at the human being in the bed before you stare at the screen. To understand why, you kind of have to look at the basic math of the heart. So cardiac output, which is the total amount of blood the heart pumps in a minute, is heart rate multiplied by stroke volume.
Right, and stroke volume being the actual, physical amount of blood pushed out with one single squeeze.
Exactly. So let's say you have a 22-year-old marathon runner sleeping in your bed.
Okay.
Their heart muscle is incredibly strong. Their stroke volume is massive. Every single time that heart beats, it pushes a huge wave of blood.
Oh, I see.
Yeah, because it's so efficient, the SA node doesn't need to fire 70 times a minute to keep their body oxygenated. For them, a resting heart rate of 38 is perfectly healthy.
Okay, but what if I have a 70-year-old patient who just suffered a massive heart attack?
Right, totally different scenario.
Because their heart muscle is damaged. Their stroke volume is super weak. If their heart rate drops to 38, their total cardiac output is just going to completely tank.
Which is exactly why you look at the patient. If that 70-year-old is laying there, they are going to show you signs of decreased perfusion. They'll look pale. Their skin will feel, cool and clammy.
Because the body is pulling blood away from the skin to protect the vital organs, right?
You got it. And they might be confused or dizzy because their brain is starving for oxygen.
Or they might complain of sudden crushing chest pain because the heart muscle itself isn't getting enough oxygen to survive.
Exactly.
Okay, so I walk in, the rate is 38, the patient is pale, lethargic, and their blood pressure is dropping fast. I need to intervene.
Right, they are symptomatic.
The classic medication here is atropine. But how is pushing a drug actually going to fix the electrical power plant?
So atropine essentially cuts the brake line.
The brake line.
Yeah. Your heart is constantly receiving signals from the vagus nerve, which is part of the parasympathetic nervous system, telling it to rest and digest.
Okay.
Atropine blocks those signals. It basically takes the foot off the brake, allowing the SA node to fire faster and bring the heart rate back up. Brick has this great clinical trick for it. Atropine puts the heart rate high, like on top of a pine tree.
Oh, wow, atropine on top of a pine tree. That is actually super helpful. And if cutting the brake line doesn't work, what then?
Then we anticipate moving to transcutaneous pacing. That's where we put external pads on the patient's chest and back and literally force external electricity into the heart to make it beat at, say, 70 beats per minute.
It's basically a bridge to keep them alive until we can get them a permanent pacemaker.
Exactly.
Okay, so that's what happens when the main power plant just runs out of steam.
Yeah.
But let's move down the heart's electrical grid. What happens when the main power plant is doing its best, but the local substations completely rebel and start firing off their own electricity?
Yeah.
That brings us to atrial fibrillation, or A-Fib.
Right, and this is a completely different mechanism of failure. In A-Fib, the atria, which are the top two chambers of the heart, they basically stop listening to the SA node.
They go rogue.
Completely. Instead of one unified electrical spark, you have hundreds of tiny disorganized sparks firing off at the exact same time.
Meaning the top of the heart isn't doing a nice, strong, unified squeeze anymore. It's just sitting there quivering.
Yeah, it literally looks like a bowl of gelatin just jiggling.
And on the monitor, you lose that nice little bump before the big spike, like the P wave is completely gone, replaced by this chaotic, wavy baseline.
And the rhythm becomes what we call irregular.
But I actually have a serious mechanical question here.
Sure.
If the atria are quivering at, say, 400 beats a minute, why isn't the whole heart just vibrating to death? Like, what is stopping that chaotic electrical storm from destroying the bottom half of the heart?
That is the magic of the AV node.
The AV node?
Yeah, the AV node sits right between the top and bottom chambers, and it acts exactly like a bouncer at a nightclub.
Okay, bouncer.
When 400 chaotic electrical signals rush the door, the AV node blocks most of them. It only lets a fraction of those signals pass through to the ventricles.
So the bouncer is keeping the heavy lifters, the ventricles, from beating 400 times a minute.
It creates massive bedside dangers. Two major dangers, actually.
What's the first one?
The first is a mechanical plumbing issue. When the top of the heart just quivers instead of squeezing, blood isn't moving efficiently. It just sits in those chambers and it pools. And what we know from practice is when blood stays still, it clots.
Oh, right. And if one of those clots forms in the atria and then eventually gets pumped down to the ventricles and shot out into the body.
Yeah, it is a direct highway to the brain.
Which causes a massive stroke.
Exactly. This is the exact reason why, when you are doing your morning med pass, almost every single patient with a history of A-Fib will be prescribed an anticoagulant, a blood thinner. We have to prevent those clots from forming in that pooling blood.
That makes total sense. So that's the long-term risk. But what is the immediate life-threatening emergency I might see on my shift?
That happens when the bouncer at the nightclub gets overwhelmed.
Uh-oh.
Yeah, the AV node starts letting too many of those chaotic signals through to the bottom of the heart. Suddenly, your patient's ventricles are trying to beat 150 or 160 times a minute. We call this A-Fib with RVR, rapid ventricular response.
And here's an amazing bedside aha moment. When I was a student, I thought a faster heart meant more blood pumping.
A lot of people think that.
But when the ventricles are beating 160 times a minute, the heart literally does not have time to relax. And if it doesn't relax, it can't fill back up with blood.
Right. It is squeezing on empty. The cardiac output plummets. Your patient will suddenly become hypotensive, breathless, and their pulse will feel incredibly fast, but totally chaotic.
So the intervention here is totally counterintuitive to a layperson. We actually want to give medications to slow the heart down, which will magically increase their blood pressure.
Exactly. By giving a calcium channel blocker like diltiazem or an antiarrhythmic like amiodarone, we are basically reinforcing that AV node bouncer. We slow down the signals getting through.
Okay.
And when the heart rate drops back down to 80 or 90, the ventricles actually have time to fill with blood again, the stroke volume increases, and the blood pressure comes back up.
And what if the medications don't work fast enough and the patient's blood pressure is totally crashing?
Then you are preparing for a synchronized cardioversion. The doctor will deliver a timed electrical shock that hits the heart at the exact right millisecond to essentially reset the electrical grid. You're trying to force the SA node back into control.
Wow. Okay, so we've seen the main power plant slow down, and we've seen the local substations in the atrium mutiny.
Right.
Now we move down to the heavy lifters, the emergency backup generators, the ventricles.
Here we go.
What happens when the cellular tissue in the ventricles gets irritated and decides to spark early, completely off script?
You get premature ventricular contractions, PVCs.
Okay, let's talk about what that looks like on the screen. Because a normal QRS complex, that big sharp spike that represents the ventricle squeezing, is usually very narrow, right?
Yes, it's narrow because the electricity is traveling down the heart's specialized, super-fast electrical highways, which are called the Purkinje fibers.
But a PVC is wide. It is a wide, bizarre, ugly-looking complex. Why does it look so different?
Because it isn't using the highway. A PVC originates in the actual muscle tissue of the ventricle. The electricity has to travel cell by cell. It's essentially going off-roading through the mud.
Off-roading through the mud.
Yeah, and because it takes longer to travel that way, the complex drawn on the monitor is physically wider.
So it's a rogue off-road spark. But, I've had a skipped heartbeat after drinking 3 cups of dark roast coffee on a long shift.
We all have.
Right, and that's a PVC. But it didn't kill me. So when does a simple PVC cross the line from, too much caffeine to an actual nursing emergency?
It is entirely about pattern recognition. An isolated PVC in an otherwise normal rhythm is usually totally benign.
Okay.
But if you start seeing couplets, which is 2 PVCs right in a row, or you see them happening every second or third beat, you have a highly irritated heart. The ventricles are basically screaming for help.
What causes that cellular irritation? Why do the cells suddenly start misfiring like that?
Usually they are starving or their insulation is stripped. Hypoxia is a massive trigger. If the heart muscle doesn't have enough oxygen, the cells get cranky and unstable.
Makes sense.
But the most common bedside culprit is an electrolyte imbalance, specifically low potassium or low magnesium.
I always try to visualize potassium and magnesium as the literal rubber insulation on the heart's electrical wiring.
That is a brilliant way to think about it. Those electrolytes control the gates on the cell membranes. If your potassium is low, the insulation is thin, the gates can't close properly, the cells become leaky, and electrical sparks just jump out into the muscle whenever they want.
Okay, so if my patient is throwing frequent PVCs and they tell me their chest feels tight, I know those premature beats aren't giving the heart time to fill, so they aren't pushing much blood.
Right.
I need to assess their airway, apply oxygen, pull up their latest lab values to check that potassium and magnesium, and immediately page the provider to get some replacement IV fluids going.
Yes, because if you ignore those warning signs, if you leave that insulation stripped, those rogue sparks are going to completely hijack the entire system.
Which transitions us perfectly into the true nightmares, lethal rhythms.
Yep.
When the irritated ventricles completely take over, you get ventricular tachycardia, or VTach. I always liken this to a marching band that has been forced into a dangerously fast sprint.
That's accurate. On the monitor, it looks like a continuous tombstone pattern. Just wide, fast, uniform QRS complexes marching across the screen.
And there are no P waves.
None.
Yeah, what's that?
The top of the heart isn't even in the game anymore.
The marching band is sprinting at 200 beats per minute. They are organized, but they're going way too fast to play any music.
Exactly.
The ventricles are pumping so incredibly fast that no blood is filling the chambers, which means no blood is reaching the brain or the body.
It's critical.
So if I am walking past a room, I look up, and I see those tombstones, my adrenaline instantly spikes. What is the absolute first physical action I need to take when I cross that threshold?
You check for a pulse. Do not look for medications. Do not start pressing buttons on the monitor. You put your fingers on their carotid artery, and you feel for a pulse.
Why is that the defining action for VTach?
Because VTach is a physiological chameleon. It can exist in a patient who still has a pulse, meaning the heart is somehow miraculously still pumping just enough blood to keep them barely alive.
Okay.
Or it can exist in a patient who has absolute no pulse, meaning the sprinting is so fast that the heart is basically just spasming in place.
Wow.
The treatment changes entirely based on what your fingers feel.
Let's walk through those pathways then. Scenario A.
Yeah.
I feel a pulse. The patient is sitting up. They look awful. They say their chest hurts, but they are talking to me. So they are stable?
If they are stable with a pulse, you are going to use chemical restraints. You anticipate hanging IV amiodarone to try and chemically suppress those rogue ventricular cells and force the SA node back into the driver's seat.
Okay, scenario B. I feel a pulse, but it is thready. The patient's eyes are rolling back, they are drenched in sweat, and their blood pressure is like 60 over palp. They are highly unstable.
You do not have time for an IV drip to circulate. You prepare the team for an immediate synchronized cardioversion. You have to shock them back into a normal rhythm before that weak pulse disappears completely.
And scenario C. I walk in, I see the tombstones on the screen, I put my fingers on their neck, and there is absolutely nothing. No pulse.
They are clinically dead.
Yeah.
You pull the code blue lever on the wall, you drop the head of the bed, you start high-quality chest compressions immediately, and you yell for the defibrillator.
Which brings us to the final, most catastrophic dysrhythmia. If VTach is a marching band locked in a dangerous sprint, ventricular fibrillation, or VFib, is what happens when an entire stadium of people suddenly starts running in completely random directions in a blind panic.
The structure is just gone. The pumping action is entirely destroyed. The ventricles have given up the organized sprint and are just sitting in the chest quivering like a bag of worms.
Ugh, a bag of worms. On the monitor, it looks like a complete electrical blackout where only random sparks are flying. It is just disorganized, chaotic, static.
Completely.
But in the sheer panic of a code blue. How do I quickly distinguish the tombstones of VTach from the static of VFib? And, does it change my immediate clinical response?
Well, visually, VTach is uniform. The waves look the same. VFib is chaos. The waves are all different shapes and sizes. But here is the critical bedrock reality of bedside nursing.
Okay.
Your response for VFib is identical to your response for pulseless VTach.
Because a patient in VFib will never have a pulse. It is physically impossible for a quivering bag of worms to pump blood.
Exactly. So the moment you confirm VFib, the ultimate memory trick kicks in. Defib for VFib.
You must defibrillate.
You must deliver a massive, unsynchronized shock to the heart. And it is vital to understand the mechanism here. The shock does not restart the heart.
Wait, really? Because every single medical TV show has taught me that the paddles jumpstart the engine.
I know, but it is the exact opposite. Defibrillation stops the heart.
Wow.
Yeah, the shock depolarizes every single cardiac cell at the exact same millisecond. It wipes the board clean. It is a hard reboot, literally CTRL, ALT, DLL for the human body.
That is wild.
You create total electrical silence, and you pray that when the dust settles a second later, the main power plant, the SA node, remembers it is supposed to be in charge and fires a normal signal.
That is incredible. So the workflow is call for help, start chest compressions instantly to manually pump blood to the brain, get the defibrillator pads on, and shock the chaos into silence.
Yes.
And while you are continuing CPR, the team is pushing epinephrine to clamp down the blood vessels and amiodarone to calm the cellular irritability.
It is a massive orchestration of physics, chemistry, and nursing intuition.
So what does this all mean for you, the nurse, standing at the bedside? Let's zoom out. The glowing box above the bed gives you clues, but it is your clinical judgment that saves the life.
Absolutely.
You have to know what the normal electrical highway looks like so you can spot the breakdown.
You need to understand the physics of a dropping heart rate in bradycardia. You need to know why the AV node bouncer matters in A-Fib and why slowing the heart actually increases blood pressure.
Right.
You need to recognize when stripped cellular insulation causes PVCs, and you must instantly react when the ventricles take over in VTach or collapse entirely in VFib.
Above all else, remember the rule that Brooke Wallace drills into every nurse she trains. Treat the patient, not the monitor. And that actually leads me to a final, slightly provocative scenario I want to leave you with today.
Oh, this is a good one.
We spent this entire episode talking about how chaotic, squiggly lines equal bad outcomes. But I want you to imagine this. You walk into a room, you look up at the monitor, and you see a perfectly beautiful, textbook, normal sinus rhythm. It's 75 beats per minute, clean P wave, narrow QRS, perfect T wave. It is a literal work of art.
But then you look down at the bed.
You look down the bed, and your patient is blue, their eyes are open and fixed, and they have absolutely no pulse.
That phenomenon is called PEA, Pulseless Electrical Activity.
It is the ultimate betrayal by the monitor. It proves that electrical activity on a screen does not equal mechanical pumping in the chest.
Yep.
The SA node can be firing perfectly, the electricity can be traveling down the highways flawlessly, but if the heart muscle itself is too damaged, too starved of oxygen, or too compressed by fluid to actually respond to that electricity and squeezing it, the patient is dead.
It is the starkest reminder in all of medicine. You can have the most beautiful electricity in the world, but you must always trust your hands and your eyes over the screen.
Moving from memorizing textbook rhythms to actually understanding the physics and applying real clinical judgment takes time. Be patient with yourself. But understanding why these dysrhythmias happen is exactly what makes you a safer, stronger nurse.
Absolutely.
We want to invite you to watch the video version of this discussion on YouTube. Please like, subscribe, and leave a comment telling us which rhythm used to intimidate you the most.
And definitely make sure you visit supernurse.ai for incredible practical resources designed to help you bridge that gap from the classroom to the hospital floor and become the super nurse you were born to be.
We'll see you next time.
Until then.
Remember to always look at the patient.